Good morning, forum members and visitors, and thank you for inviting members from University of New England to be here today. It didn't take me 27 hours to get here, but it took longer than it should have because of the weather yesterday, and we have one member of our team that still hasn't arrived yet. So, but again, thank you for having us. University of New England, for those of you who aren't aware of where it is or who we are, we're in Maine, where we have 3 campuses. We have a campus in Portland, Maine, we have a campus in Biddeford, Maine, and we have a new campus in Tangier, Morocco, a small campus there. The Westbrook College of Health Professions is a health sciences college within the larger university. We educate the largest amount of health profession students in the state of Maine. We also do not have an academic health center, so we rely on clinical partnerships to educate our students in their clerkships and preceptorships and clinical experiences. And that's a challenge in itself, but it's a challenge that is welcome when we talk about community-based learning. We have a very robust IPE infrastructure, and we have become a national and international leader in what that message is conferring. And our president, Dr. Danielle Rippich, would say that we're a private university with a public mission, and I think that we would all agree with that we are doing a lot of good work out there in the community and that we have a very public mission in mind. And the list that you see to the right is all of the health professions within the Westbrook College of Health Professions, in addition to a College of Medicine, a College of Pharmacy, and a newly implemented College of Dental Medicine, which just opened last year with 61 students. So when we think about competencies for good work in communities, I'm going to use a project that we were awarded through the Health Resources and Services Administration about 2 years ago to frame it. And as Malawal, one of my community health outreach workers in Maine, mentioned in the last talk, that Maine is a resettlement area, believe it or not. We have 2 cities, the 2 largest cities in the state, are a resettlement area for immigrants and refugees. And although most of the state is very white, and we have a lot of other vulnerable populations as well, including very rural, poor folks, this was a project that we were able to implement with an award from the health from HRSA. So that resettlement area is a new home to 400 to 450 primary or secondary refugees annually, and about 13% of the city of Portland, Maine, where we've rolled this out, is foreign-born and English as a second language. We're also a non-Medicaid expansion state, and it's worth mentioning because for all the good work we're trying to do to educate our most vulnerable to the Affordable Care Act, when you can't expand Medicaid, it leaves our most vulnerable very confused. And when we're trying to implement trust-based relationships with those we're trying to serve in the community, it creates a tangle. So it's certainly worth exploring further. So best available evidence to inform education and practice. The direction that we took with this project, and again, we received an award to create an innovative interprofessional program that would improve health outcomes for immigrant and refugee communities in the Portland, Maine area, is based on an education, training, and service model. So there are 3 arms to this. And what we know is that we cannot train students without having a very fundamental and targeted approach when working with communities. I direct a nursing program, and historically in undergraduate nursing programs, the community and population health course has been in the final semester of the 4th year. That's pretty broken. And I suspect that some of my colleagues, interprofessional colleagues in the room would say that their programs do the same thing. So we've changed our focus to integrate population health and save the more advanced skills for that community and population course in that final semester of that of their academic trajectory. Community health needs to be integrated. It's a thread, okay? It's not a standalone course. Training, making sure that our health professionals that are out there are getting training to encourage the latest and greatest and best available evidence. And then the service side of things. And what I can tell you is it doesn't take a big award from HRSA to fix the way we educate students. A very small amount of our resources went to the education side. We did what we needed to do because it was the right thing to do. As you can imagine, the large proportion of the resources have gone to the service side. So I've heard a lot this morning about longitudinal approaches, and it's just one approach that goes along with everything else we have to do when we're making compromises with our interprofessional colleagues. One thing that we have worked really hard to do with this project is bring students from health professions together to learn integrated education. And it takes a tremendous amount of compromise to do that. So our approach has been longitudinal, it's been bicultural, and it's also been participatory with the community. And we've heard a lot about these things this morning. The other piece is that it's grounded in cultural sensitivity. And, you know, there are a lot of wonderful theories out there, and I'm a firm believer that we don't need to pick a single theory to think about when we think about cultural sensitivity, but it does need to be a theory that is on a continuum, and it does need to be, it does need to have an approach that that posits that no one ever really truly achieves cultural competence, that it's a process, and that there's no one human possible out there. It's not humanly possible. The other piece is that we integrate the 3Ds, and the 3Ds are something that's really a coined term in the nursing literature that includes diversity, health disparities, and also social determinants of health, which we've heard a lot about this morning. And what I'll say about diversity is we have a long way to go in health professions academia in creating academic environments that are rich with diversity, because that academic diversity translates to workforce diversity. And we have a huge deficit in workforce diversity. Workforce diversity helps to eliminate health disparities. So public health practice is also a fundamental principle. And our Benjamin Franklin said an ounce of prevention's worth a pound of cure. Well, he said that back in the 1800s, and we still continue to be a very disease management culture. So again, going back and integrating all of this stuff early on and not saving it for a standalone course is how we need to approach this. And so this is a very busy structure of what this project is actually all about. Our goal is to improve the health of immigrants and refugees through innovations in community-based interprofessional care. And Malawal and Siad are two of our community health outreach workers. You heard from Malawal this morning at table 6, and Siad Ahmed is at table 2. We brought them along because they are truly the driving force of how navigators, how community health outreach workers not only educate our vulnerable communities, but they educate our students and our training sites. And so if you look in the middle, and you'll see that big bubble of the expanded community health outreach worker model, we've expanded their role to educate students. And they are in our program actually assisting and educating about what navigation means and the importance of understanding culture. So if we look at these rows, the education, the integrated curriculum is actually something that we're doing interprofessionally. So we've developed a 6-hour curriculum, and that was a compromise. You know, when we got together with all the program directors to say, we're going to do this thing that you might think is impossible, but we're going to do it anyway. We had to make some compromises in just how much time individual program directors could allocate for interprofessional learning. And so, you know, one program director, I won't tell you what discipline it was, said, well, we can give you an hour. And others said, well, we can give you as much as 8. And everybody met in the middle, and we've developed a curriculum that's 6 hours long with respect to this project. And it rolls out in the fall semester, in the spring semester, and then in the summer. And so the training arm includes, again, the community health outreach worker model. It also includes interprofessional team-based training for our interprofessional clinical practice environments. So we're going out there and we're helping some of our esteemed community-based partners who are really new to interprofessional practice as our competencies dictate. And one of the interesting experiences that we've had, because a lot of our community partners involve low resource settings, medical homes, but FQHCs, is that a lot of folks out there think that they do it because they're a medical home, but in fact, it is something that has required some actual learning on their behalf. And then the other piece of the training arm, and this is not just isolated to the state of Maine, is that public health nursing is very under-resourced. And our state public health nursing agencies are so under-resourced that we can't build capacity. And so part of what we did with this grant was we developed a public health nursing institute that actually provides public health nurses that are out in the field with advanced public health nursing skills as well as leadership. And we just graduated our first group of 11, and it will go on next year. And then our service side, again, the interprofessional clinical practice environments included the rollout of a new health center, part of an FQHC, an oral health program, and also public health activities. And the public health activities, I really underscore that as being really a really critical arm of it. We've had about 50 public health activities to date. The community health outreach worker model, again, this model, and really, it really utilizes IHI's triple aim as not only a guiding framework, but an evaluation framework. That population outcomes, the patient-centeredness and lowering costs is what we're thinking about and what we're trying to instill in students. If we can get this sense of systems thinking and the macro sense of resources and cost into them at an early time, again, integrating the concepts, then we've come a long way. And so the expanded community health outreach worker model could translate to any vulnerable population. They are members of our healthcare team, and we're measuring that. Talked a little bit about the evaluation framework already, and some of the evaluation tools that we're using with the education arm are what we do in education, our formative and summative assessments, our curriculum, the cultural sensitivity piece that I talked about earlier. And we're also doing a lot of measurement in attitudes and behaviors surrounding IP education and care. Team Steps is our model of thinking about communication, quality, and safety. And talk about a small world. Our Team Steps training we received from the University of Texas, and I see Eileen Breslin is here. And our service side is measuring what we do in all service venues. We use utilization reports, we use EMR, and we measure satisfaction through CAHPS. This isn't an advertisement, but rather an illustration of what it takes to do community-based collaborative projects. And all of these folks have played an integral part in rolling this out. We're about to complete year 2 and move on into year 3. But thank you so much.